let's talk about recurrence. So we've gotten through first-line therapy, and now the cancer has come back. What do you guys use for second-line therapy, and why?
Yeah, so the data with Taxol and ramucirumab is level 1 evidence that that's superior to Taxol alone. So that's a standard that we use. There's also data that a doublet, so using platinum and S1 versus cisplatin alone S1 alone in the second-line setting, actually there was no difference in survival. So I'm not sure that a doublet makes a lot of sense in the second or third-line setting. It's mostly a monotherapy treatment or Taxol with Cyramza.
Now, Ian, you don't have access to ramucirumab in the UK.
Yeah, so we don't have routine access to it because this is not funded by the government. So, for patients who have access to it, then like what Manish said, that would be our preferred standard to give them paclitaxel plus ramucirumab. And of course, finding the appropriate clinical trial for them would be a very essential goal. There has been a lot of studies on immuno-oncology compounds, although, that trials obviously open and closes. So off study, we do consider weekly paclitaxel on its own, which obviously we have good results. That itself is a good treatment, but if we do have access to ramucirumab, we do generally like to add on ramucirumab. But I think, when we go on to that, and I suppose is, thinking about the whole patient journey, is how much neuropathy does the patient have? And in a way, I talked about early on, we're trying to avoid oxaliplatin for that reason. But equally, I think the way that how I interpret both Rainbow and Regard is, ramucirumab have single agent activity. So if people are running into neuropathy, I do actually have confidence to maybe take the paclitaxel off and run them on ramucirumab.
Well, let me pause you there.
Okay.
Can we refresh our audience on, tell us about Rainbow and Regard and what we saw, and why even in the UK, if you can get it, you're going to give a patient ramucirumab.
Okay, so those are two randomized controlled trial. Regard is single agent ramucirumab, placebo control, so therefore the control group have best standard of care and no other active cancer treatment. And it is a 350 patient trial done in multiple countries, and what it showed is single agent ramucirumab did show a significant survival advantage over placebo alone. And this is actually the first randomized control trial that shows a antibody against VEGF actually show a survival advantage. Because remember, all the data with bevacizumab is in conjunction with either chemotherapy or interferon or whatever they were using in the tumor types. So, it does, and also we do know that the safety profile for single agent ramucirumab is extremely favorable. We certainly, when we were doing the study, we don't know who's on placebo, who's on drug, and now the data are out. You can see that compared to placebo, in fact, the side effects are almost the same. I think the main difference probably is hypertension, and the hypertension is managed quite adequately by antihypertensive medications. Almost in parallel, although perhaps slightly later, the Rainbow study was conducted, again in many countries, because of course, in many countries, giving chemotherapy is a standard of care. So in that study, the chemotherapy backbone is weekly paclitaxel. And then there was experimental arm is the additional ramucirumab, again placebo control. Again, this is actually a bigger study, over 600 patients recruited in those studies, and again they show a significant survival advantage. Now, if you look across the board, you actually go from having best standard of care in that setting of only median survival about 3.6 months, you now almost triple the survival when you add paclitaxel plus ramucirumab to over 9 months. So, so therefore, I think if one have access to it, I would say it is a valuable treatment to have. As I said, if one runs into either neuropathy or really problematic neutropenia, then maybe stopping paclitaxel for a while and with monotherapy ramucirumab is also an option.
Now, it's really interesting. One of the reasons that bevacizumab, the study, the AVAGAS study, which was a first-line bevacizumab study, came into controversy was because it was done across the world. And we talked a little bit earlier of, is there some sort of biologic and probably multifactorial, but some kind of underlying biological difference between the Asian and the rest of the world populations? Because there, in AVAGAS, we did not see any benefit to bevacizumab added to chemotherapy. What did we see for Rainbow in the Asian populations?
So I think, first of all, what we saw in AVAGAS is that, as you said, the Asian really don't seem to derive any benefits from bevacizumab, either in progression-free survival or overall survival. Whereas, the Pan-Americans seems to have some benefits. And because if you only see no difference in overall survival, but you do see a progression-free survival, you might say, well, maybe because the Asians are getting second-line, third-line, fourth-line treatment, and therefore it just diluted out the overall survival. As I said in AVAGAS, and Manish, please correct me if I'm wrong, there was the PFS was also not in favor in the Asian population for bevacizumab. But for Rainbow, again, yes, I mean, it is a subgroup analysis, look at the Japanese versus the Western population. But there they actually saw a progression-free survival advantage for ramucirumab in the Japanese as well as the Western population. Although for the overall survival, yes, they were seen in the Western population and not so in the Japanese. But I think there we know 75% of the Japanese population actually have post-progression therapy in that study. So they were getting third line, 3/4 of them was getting third line, fourth line, fifth line, whereas the Western population was only about 1/3 of the patients get subsequent line therapy. So I think there really perhaps the lack of overall survival benefit in the Japanese population is probably because of subsequent line therapy. So, but the biological effect is there. So I think therefore ramucirumab is well accepted in the Japanese oncological community.